Hi, everyone. I'm Peter Coyle, and I'm assistant professor in the Department of Physical Therapy at the University of Pittsburgh. And today I'm going to present my work on investigating care pathways back to the community for stroke survivors. And specifically, we're going to emphasize the system science aspect of this work. Just a little bit of background about myself. I was a LeaRRn visiting scholar. So the visiting scholar program, you can find more information on the website. But essentially, the visiting scholar program is where a rehab researcher is partnered with a healthcare system for 12 months to focus on preparing a research project or quality improvement project that is central to a priority area that the healthcare system has identified. And so that piece is information. This is really driven by the healthcare system and real issues that they're experiencing. So between 2020 and 2021, I was partnered with UPMC, which is based in Pittsburgh, Pennsylvania. And UPMC, for those who aren't familiar, is a highly integrated health network that offers the spectrum of healthcare services from hospitals all the way to rehab services and primary care clinics out in the community. And my work was really with the Centers for Rehab Services, so the arm of UPMC that provides all of rehabilitation for the patients within that system. And they offer the full spectrum of rehab services from the hospital to the community. And they are one of the largest rehab providers in Pennsylvania, and they see hundreds of thousands of patients annually. So this is a big healthcare system that we're talking about. And they wanted to collaborate with LeaRRn to focus on their post-acute care of rehab services. And I will get into more details about the specific project in a few slides. But first, let's talk about the presentation objectives for today's talk. And by the end of the presentation today, you should be able to apply elements of basic system science principles to rehabilitation research design. You should be able to illustrate how select rehab services are organized within the post-acute care domain of the healthcare system. And you should be able to identify how aspects of financing, organization, delivery, and/or outcomes for each one of those post-acute care settings influence one another. So the interdependency of different aspects of the post-acute care system. So before we hop into the project, let's just go through some of the background and talk about what exactly system science is for those who aren't familiar. So system science and this idea of systems theories was really born out of manufacturing. And the general definition, very broad here, is just seeing how things are connected to each other with some notion of a whole entity. So how these different parts work together to produce some sort of outcome or product or something of that nature. So what does that specifically mean for healthcare? So applying it to healthcare, it's the fundamental understanding of how care is delivered, how healthcare professionals work together to deliver that care, and how the health system can improve patient care and healthcare delivery. And this is a good point to point out that a good spot to point out that throughout the presentation, you will see these references, which are actually hyperlinks that will take you directly to the references that I'm citing here. So feel free to download the presentation and click on those to learn more about each topic. And I strongly encourage you all to look at Atul Gawande, who's a surgeon and a researcher and an academic, who published an article in the New Yorker called Cowboys and Pit Crews, which talks in very broad and lay terms about the birth and future of health systems. So if you're like me and you come from a more conventional clinical research background, it's probably important to talk about what system science is not. So system science is not a narrow focus on improving singular clinician and patient interactions or outcomes. So things that focus on diagnostic accuracy or treatment efficacy in the strict sense. And it's not biological or clinically mechanistic based research. And so what do I mean by that? So for an example, biological example might be muscle morphology's impact on muscle function. And a clinical example might be looking at range of motion as a risk factor for poor performance-based function. So these are examples of what system science is not. And why is it important that we discuss system science? Well, patient wellness often depends on the health system's performance as a whole and not one specific component. And as such, we're shifting more towards value-based care. So in the past, it was all more volume-based reimbursement, where you were paid a fee-for-service kind of model. If you provided a service, you were reimbursed for it. But now value-based care, which is shifting payment policy towards incentivizing providers to provide better treatments to lead to better outcomes at lower costs. It's really important to understand how all of the parts of the system work to generate those outcomes that payers and patients really care about. And finally, it's becoming the third pillar of clinical education. This is a shift that's happening more so in medicine at this point, but if you think about clinical education for all healthcare providers being some combination of basic and clinical sciences, now system science is creeping its way in to equal footing with those two aspects of clinical education, just because of the way the overall healthcare policy and systems across the country are shifting. So now that you have a firm background and understanding of what system science is, let's shift gears back to the project at hand. So UPMC, Centers for Rehab Services, or CRS, had received some alarming news that kind of sparked this whole project. And what they found was patients in their inpatient rehab network, only about 15% of those or less were actually transitioning to their outpatient rehab facilities, which is a big problem. If you think about the patient population that the inpatient rehab network sees, by definition, these are people who need intense and frequent rehab. So it would make sense that, a larger number of these would need outpatient services, that they're not going to be better just at the end of their bout of care in inpatient rehab facilities. And specifically, UPMC and CRS wanted to focus on their stroke population. So people who survive a stroke often have physical and cognitive limitations, and we're finding out that that's particularly prevalent and happens incredibly frequently in the patient population, more so than we originally thought. And there are well-documented problems with care transitions for these folks. And so we know that early and intense rehabilitation is key for people with these neurologic impairments. So it's really imperative that we get these people to the right care at the right time with the right providers. So what is the post-acute care system overall? It's comprised mainly of four different, broadly different categories. There's skilled nursing facilities, the inpatient rehab facilities, home health, and outpatient rehab. So that's really what we mean when we say the post-acute care aspect of the health system, the post-acute care domain of the health system. And this graphic is really just to illustrate how complex the patient interactions are in each one of these settings. So each post-acute care setting has a specific structure and processes that they provide, so guidelines that they follow, the frequency and timing of therapy that they deliver, and the specific interventions that they deliver to generate some sort of outcomes that are important to that particular setting. So any things like performance-based measures or self-reported measures, things of that nature. And those processes and outcomes are influenced by the external healthcare environment and the environmental context. So, like how much family support that somebody has, the sort of health insurance that they have, things of that nature. And all of those things work together to generate these sort of macro outcomes or system level outcomes that providers and patients really care about. So their activity, participation, disability levels, their health related quality of life, where they're discharged to next, and their overall healthcare utilization. So the purpose of our study with UPMC and CRS, we really wanted to focus on those people who survived the stroke who were ultimately ending up back in the community and describing the care pathways that they take from hospital discharge back to home and identify where those breakdowns are occurring. In addition to that, we wanted to start to identify some factors that were potentially influential in the care transition process. And our goal was really to better understand the problem of the care transition and the care pathways here. We know broadly that there are some breakdowns that are occurring in a lot of people who are not ending up in outpatient therapy where we would thought they would. There's good reason to think that they would. And the emphasis here, often when we think about quality improvement and improvement science, we think about this in the Plan, Do, Study, Act context, which is a kind of a conceptual model to help guide the process of learning health systems. But what we're finding, what experts are finding, I should say, is that planning paralysis, while that can be a problem where people get stuck in the planning phase, it's a more common problem that there's a lack of investment in the planning phase and really understanding the context of the issue at hand so you can start to implement interventions. And that's just a common issue that happens in clinical research as well. We always want to jump immediately to forming better interventions without necessarily understanding the underpinnings of how those things work and what are the particular underlying impairments that we need to address. And so this project was really focused on understanding the problem. And if you think about, again, conventional clinical research, this is really akin to collecting your preliminary data, your pilot data, to start to make the argument for taking action. So I just want to take a brief moment to describe the team model and how we identified who the players were that were integral to this project. And so I was a health system scientist that worked on it. We had our clinical operations leaders who were directors of rehab services that really set the vision and understand the logistics of care delivery. We had data stewards who understand how to leverage the EHR and process that data. We had technical leaders that were more responsible for the broader server management, data architecture, and sometimes those people were one and the same, the data stewards and the technical leaders. And then finally, we had regulatory experts, administrative folks who, were responsible for the ethical navigation of this project, how to deal with the data, how to make sure that human subjects were protected. And so in our study, we had a mixed methods design. First, we had a qualitative arm of the study where our science team or our LeaRRn team, which comprised of both myself and clinical operations leaders, worked together to really understand. They helped me understand the context of the problem, and I helped them sort of operationalize a lot of the things that they were talking about so that we could have an informed approach moving forward in identifying what variables that we needed. So anybody who's worked in research or in healthcare knows that health systems collect a ton of data, and it's not always feasible to look at everything. So this was really getting a good conceptual understanding of what was important to come up with a comprehensive but parsimonious data set, only the variables that we actually needed. So first, we generated a process flow map. And just to draw your attention to the flow map here on the right, this was really to understand conceptually what was happening to these folks. So when folks were discharged from the acute hospital setting, the first question that was asked was it safe to go home? And if the answer to that question was no, the follow-up question was, could they tolerate and benefit from very intensive therapy services? The answer to that question was yes. They went to inpatient rehab facility. The answer to that question was no. Maybe they were a little bit more medically complex or necessarily couldn't benefit from that type of intensive therapy. They went to the skilled nursing facility. From there, when they were ready to be discharged back into the community, or if right from the hospital, it was safe for them to go home. The question was then, were they homebound? If it was yes, they went to home health. If it was no, they went to outpatient rehab. And so this is kind of a breakdown, but still rudimentary and a 30,000-foot view of what actually happens through the post-acute care continuum. And this process flow map really helped us identify additional key stakeholders to build out our advisory team to understand the problem in the context of care transitions for these patients. And it helped us detect some key questions for discussion, but ultimately, what the real value of this was to identify the variables that were necessary for quantitative analysis, to identify what were the things that we thought were most salient in doing this project. And so this was an iterative process. So we had our process flow map, and we worked with clinical operations leaders, and we went back and forth about what were the factors that were most influential here, and whether or not this process flow map was an actual accurate depiction of what was going on. And so we went back and forth until we came up with a process flow map that we thought really accurately reflected what was happening in the UPMC environment. And so, we went through several revisions of the map, and I just want to go over a couple of examples here. And what we found was that few patients were moving from the SNF, or the skilled nursing facility environment, back into the community. And data requests are very time consuming for working in healthcare systems. And so we decided the juice just wasn't worth the squeeze, because these were not patients that were ultimately ending up back into the community. It wasn't really part of the cohort that we were interested in. In addition to that, this iterative process really helped us reveal what factors were influential in answering these questions, right? So these questions, whether or not somebody's homebound, is not necessarily so straightforward. It depends on things like insurance status and their socioeconomic status, what their cognition was, if they had insights into their deficits, or if they had family support and caretaking to travel, potentially to outpatient rehab and back. And so our quantitative approach from there was also iterative. We worked with data stewards and regulatory experts to identify the data sources that contained the information that we really needed to answer our question, and what those variables were and what we could actually access. So patient health characteristics, demographics, states of service, care processes, outcomes. And again, we had to refine our approach here. We found that we weren't able to obtain zip code data to protect patient health information. And we had to actually perturb the dates of services that were provided so they couldn't be immediately linked back to any one particular patient. So again, another iterative process that required all hands on deck from different aspects of the healthcare system. And from there, we obtained a comprehensive data set. We're actually still in the process of doing this, but our process map was comprehensively but not exhaustively outlined. We removed all of the potential identifiable data from the data set before we accessed it, and we aggregated it and harmonized it between the different data sources, right? So some of these variables come from billing data, some of these variables come from the clinical record and the electronic health record. And now we're constructing our 6 months episodes of care to really illustrate what's happening in these care pathways. So in the future, we're probably going to undertake a similar qualitative or iterative process where we have our quantitative findings to go back to our advisory board, and we ask them, does this make sense? Does it not make sense? Are we missing something here? And then from there, we take that information and we reapply it to pulling the data that we need to answer these questions. Okay, so like I said, the work is ongoing, but there are still some good takeaways from this particular case to help you understand some system science approaches here. And first is, in this presentation, we illustrated how the post-acute care rehab services are organized and how they're interrelated to one another. We've demonstrated how a health system conceptual model, so the solutions team model that I presented before with those various stakeholders, health system scientists, clinical operations leaders, data stewards, the technical expertise, and the regulatory oversight, how they can all inform study design and the variables that you could potentially access and collect. And we showed how a tool, quality improvement tool like process mapping and stakeholder engagement can really help refine and focus quantitative investigations, which I think is a really important piece, again, for people who are coming from a more conventional clinical research background, where they might not have considered these tools or approaches before. All right, I want to thank you guys for listening to the presentation. My email address is up here in case you have any questions, and good luck. And I hope that you found this presentation interesting and pushing you more in the direction towards pursuing some learning health systems research.